This meeting is being recorded. So, yeah, thanks for joining us. We're joined today by Dr. Frances Seymour, who's one of my colleagues, who's a consultant hematologist at Leeds Teaching Hospitals, where she specialises in treating myeloma. Her research interest has been in the function and dysfunction of the immune system in multiple myeloma. And she's going to talk to us today about the interaction between the immune system and its failings in myeloma and physical fitness in myeloma, which is something that we know is of a lot of interest and something that we're looking at in lots of the studies that are coming through in CARP and other parts of the LICTR program. So with that, I'll hand over to Frances. I think she's planning probably to talk for about half an hour, and then so we should have some time for questions afterwards. So if people have got questions, either pop things into the chat or at the end, put your hands up and I'll come around people in due course. Thanks, Frances.
Right, thanks, Chris. Let me just share my slides with everybody. Right, I hope that people can see my slides now. I can't actually see you anymore, so if somebody could just shout to say that you can see my slides.
Yeah, we can see them.
Looks good.
Brilliant. And if for some reason they don't move on, or if there's any technical issues, just give me a shout and we'll deal with it as we go. So as Chris said in his introduction, I'm going to talk to you today about both immune and physical fitness in myeloma and how the two interact. And I think of this as the clinical risk factors for myeloma. So we're going to talk quickly through immune and physical fitness in myeloma, and then we're going to touch on the practicalities of how we could or how we should assess this in clinical practice. And then I'm going to very briefly think a little bit about what the future might hold. I'm not going to talk in any great detail about the sort of forthcoming clinical trials, because I know a lot of people on this call will know far more about that than I do, but just a little idea about where we're going and maybe what some of the questions need to be for the future for our research in myeloma. And so whenever we think about clinical risk factors in myeloma, I think we're broadly thinking about three different areas. We're thinking about the myeloma itself and the biology and the characteristics of the myeloma and how that affects its behaviour. And that might relate, for example, to any particular genetic changes within the myeloma. But we're also thinking about how these myeloma characteristics interact with an individual's immune fitness and also their physical fitness. And this is important because it's the interaction of these three different characteristics that can really drive how myeloma responds to treatment, but also a lot of those toxicities that we see with treatment. So I'm not going to talk at all about the myeloma characteristics today, but I am going to focus on these immune and physical aspects. And within these two broad groups, there's really an awful lot of different areas that we can think about. So within immune fitness, we've got the behaviour of the cells themselves. So whether they are functioning in a normal way or whether there are abnormalities in the way that they're functioning. And we often think about this and describe this in terms of exhaustion, where the immune cells have lost their ability to perform their normal functions, and senescence, where cells have the potential to function in a normal way, but aren't able to grow and replicate and divide in the normal way. But there are other aspects to immune fitness as well. So there's the vast range of different immune chemicals that are produced by our immune system, and particularly our cytokines. And these profiles can change in myeloma. And we've got the different metabolic pathways within our immune system, which are really being driven by mitochondria within our immune cells, and which we think are particularly important for the way our immune system behaves. And then on the other side of the scale, we've got all of these different aspects of physical fitness. And age is a component of that, but it's not the only component, and it's probably actually not the most important component. What's probably more important is our ability to live independently and to do all of the different activities of daily living that we want to be doing, but also the other health problems that we suffer from. That could be cardiovascular or metabolic problems, for example, strokes, heart attacks, diabetes. But that could be aspects like muscle strength, which may not be directly related to a particular medical condition, but may be a gradual deterioration with time and may be more related to the choices we make about our physical activity rather than our age per se. And then finally, we've got our cognitive function, how our thought processes and our ability to use and think about information might be affected by the presence of the myeloma. So there's an awful lot of different components that are playing into this. And I think it's important that we set this in the context of why it's important to think about physical fitness as well as immune fitness in the setting of myeloma. And one of the first things that we need to acknowledge is that myeloma is a disease of older age, and that actually the majority of the patients that we see in a clinic are probably and increasingly over the age of 70 and beyond. And this really reflects our population as a whole. We know that our population is ageing, and we know that the predictions, and these are from the Office of National Statistics, we know that the predictions of people who are going to be in their 60s or in their 70s over the coming decades is increasing. And we know that overall our life expectancy is also increasing. But there is a concern that our general levels of ill health as we age are rising. And what this graph is looking at is what they describe disability-free life expectancy, or the period of our life that we can expect to be leading a healthy life before we're significantly impacted by various different health conditions. And the worry is that as time goes by, the length of good health that we have within our life expectancy is falling, although our life expectancy overall is rising. And really strikingly, this is really affected by our level of social deprivation. And this is from Chris Whitty's recent Chief Medical Officer annual report that was only published a couple of weeks ago. But I think this graph is really striking. What it's telling us is that those individuals that live in the 10% of the most deprived areas in the UK have a shorter overall life expectancy, but also a much longer period of their life spent living in poor health compared to those that live in the least deprived parts of our society. Now, this is really important when we think about particularly clinical trials, and particularly clinical trials where we're focusing on an older age population, because if our trials don't accurately reflect the real world populations, then we may be seeing survival statistics that actually aren't reflective of what's true of our society in general. And then when we think about specifically myeloma, we recognise that we have a whole array of fantastic new treatments for myeloma. And it feels like every couple of weeks there's another fantastic new treatment coming along. But the actual reality is that most of these treatments are benefiting our younger patients much more than they're benefiting our older age patients. And this is some data from Myeloma 11, just looking at the impact of age on progression-free survival. And it's really striking the difference between those over the age of 80 compared to those under the age of 60. So there's a big area of unmet need here. And that's where trials like the fitness trial are so crucially important, because it really beginning to focus on those age categories where we haven't seen that benefit in progression-free and overall survival. The idea of the immune system function and physical fitness in the setting of myeloma is also important when we think about some of the newer drugs that are coming through. And we're moving really into an era now of immune-based treatments for all cancers, but particularly for blood cancers like myeloma. And in order to be able to harness the power of the immune system, we need a well-functioning immune system. And what we can see in this picture is we've got a CAR T cell on the left, and we've got a normal T cell, but being brought into contact with the plasma cell with a bispecific in the middle. And it's not just the function of these CAR T cells or these T cells that are important, because they're not alone in killing the myeloma cells. What they do is recruit a whole load of different immune cells to the site of the myeloma, and it's this immune system activity together which is responsible for myeloma cell killing. So we need every component of our immune system to be working optimally in order to get the most benefit from these treatments. So if we think just in general terms about the normal link between biological aging and normal changes in the immune system, it's well recognised that as we get older, there are very natural changes that happen in our immune system and that affect all the aspects of our immune system, both the cells of the immune system, but also the chemicals made by those cells of the immune system. And as we get older, the immune system changes into a system where we have this low level of long-term inflammation. And this low-level inflammation predisposes us to developing a whole host of different medical conditions. So this is where the link comes into metabolic diseases, including obesity as well as type 2 diabetes. We also see accelerations in joint damage, and this leads to various forms of arthritis as well as to osteoporosis. We see increasing rates of high blood pressure, of heart failure, and of atherosclerosis that then leads to other problems like heart attacks and strokes. We also importantly see an increase in different neurological diseases. This includes diseases like Alzheimer's and other forms of dementia, but also diseases such as Parkinson's disease and increasing rates of depression are also linked to this chronic inflammatory state. And finally, we see a range of different cancers associated with this inflammatory state. And this includes the solid organ cancers, the carcinomas, the melanomas, but it also includes the blood cancers like myeloma. So we know that normal aging itself is linked to changes within the immune system. We also know that myeloma is very strongly linked to changes in the immune system. And this is my particular area of interest when it comes to the lab-based research, and this is what my PhD was focused on. And the interesting thing about blood cancers and myeloma in particular is that the cancerous cells themselves are part of the immune system. So as part of their normal processes, they are communicating with all the different cells of the immune system. And when plasma cells become cancerous plasma cells, they're still able to communicate with the immune system in the usual way, but they can start to manipulate or modify the immune system for their own purposes, to create an environment around themselves which helps to protect them and that favours their growth and their reproduction. And we know that in myeloma, if we look at almost any cell type in the immune system, we can see changes that are present in myeloma, but aren't seen in people without myeloma who are of a similar age. And I've just included 3 examples on the right here. So we see this in all of the myeloid cells, we see this in the regulatory cells, and we see this in the natural killer cells. But you could pick any cell in the immune system and you're going to see these changes in the setting of myeloma. So what happens when we integrate these different elements together? So we start with the normal biological process of aging and the fact that as we age, we develop a more inflammatory change in our immune system, which is linked to chronic diseases of aging. And alongside this, we see changes in people's physical fitness. And this is often referred to as the frailty spiral. And this isn't just related to the different diseases that people have acquired as they age, but also to the aging process within our muscles and within our bones that can cause us to develop weakness as we get older. Now, the frailty spiral really relates to our ability to do our normal functional day-to-day activities. And when we're living completely independently with a good state of general health, then whenever we encounter a minor illness, we might have a brief and mild step downwards in our independence, but then our independence returns to normal levels very quickly and life carries on as normal. But when we're entering the frailty spiral, what would have previously been a minor illness becomes much more significant, and the drop in our independence is much more marked. It takes a much longer time for us to recover, and we may never recover to the level of function that we had before we developed this illness. And if you suffer from multiple minor illnesses one after another, then you spiral downwards and downwards and downwards in your functional ability and your level of independence. And then we add myeloma as an overlay on top of this. So what does myeloma do to this picture? Well, first of all, we know that myeloma has all sorts of different physical impacts. It causes anemia, it causes renal disease, it causes bone disease, and all of the pains and fractures that can cause. And these different changes are going to have very obvious impacts on our physical fitness. And as we've already discussed, myeloma causes immune changes and so immune dysfunction, but also an increased rate of infections. So people may be suffering more and more and more of these minor illnesses, which push them further and further down the frailty spiral as a consequence of recurrent infections. But they also have changes in their immune system that are myeloma related, that are also interacting with these normal biological changes of aging. And then on top of all of this, we throw then a whole range of different medications at the myeloma. And these also have an impact on somebody's physical fitness. And steroids are an absolute nightmare for this. We know that steroids are really crucial to almost every combination of treatment we give for myeloma, but we also know steroids cause a whole host of physical and mental side effects that can really be quite problematic for our patients. And so what we think really is happening here is a two-way conversation between the myeloma and the biological processes of normal aging. The myeloma can be accelerating our natural aging, but our natural aging itself can be predisposing us to the effects of myeloma. And we can see some of this when we look at the immune system in the lab. And we're doing some work at the moment looking at some of the clinical trial samples from myeloma 14. And what we're looking at in particular is the senescent cells, so cells that have the potential to work normally but aren't able to grow and divide in the normal way. What you can see over on the left here is that we see more of these cells in myeloma than we do in control individuals that don't have myeloma. And we see more of these cells in newly diagnosed myeloma than we do in the first relapse of myeloma. But really importantly, on the right, we can see that there's also a relationship between physical fitness and the levels of these immunological changes that we see. And we see far more of these changes in people that are both frail and have myeloma. And we don't think that this is an age-related change alone. I've not shared this data with you, but this doesn't correlate directly with age. It seems to be much more related to physical fitness and these senescent immune cells. And we also suspect that these immune system changes may be driving some of the physical health changes that we see. Now, this isn't yet an area that's been thoroughly explored in myeloma, but it's where we're hoping to move our laboratory-based research to over the coming months. So what I've shared with you here on the right is some data from a Spanish research group that did a really interesting piece of work looking at some populations of mice. And they had two groups of mice who were in all ways identical, except that one group of mice had a very specific change in their mitochondria within their T cells in their immune system. And mitochondria are responsible for all of the energy production in our cells. So if our mitochondria aren't working normally, then a cell can't grow, it can't divide, and it can't do its normal activities that it should be able to do. So these mice just had a very slight change in their immune system. But what you can see at the bottom is that there's a very marked difference in the physical well-being of these mice. So these are two mice of the same age, but the mouse on the right has this immune system problem and the mouse on the left has a normal immune system. And the mouse on the right clearly looks much more frail and more elderly, really, than the mouse on the left. And when this team looked at the overall physical fitness of these mice, they found that their body weight was lower, their muscle strength was lower, their cardiovascular fitness was lower, so they had problems with the heart that the non-affected mice didn't. And when they looked at the different immune chemicals that were being produced, there was a real shift towards those chemicals that we see in the setting of chronic inflammation. So this suggests that in mice at least, very simple changes within the metabolism of our immune cells can have really widespread changes in physical fitness. And we think it's plausible that similar things are happening in myeloma, that we know that there are changes that myeloma can make to the immune system that have the potential to change our metabolism within our cells. And that these changes in turn could then go on and have all of those knock-on impacts on our physical fitness and well-being that we've already described. So this is an area of sort of active interest at the moment, and it'll be interesting to see where this leads us. And then finally, in the more real-world setting, when we actually come to treating myeloma, we know that both age and physical fitness matter. And this is, again, some data from Myeloma 11 that broke down outcomes according to age, and then within each age group, broke down outcomes according to physical fitness. And within each age category, the fitter you are, the better your outcomes from your treatment. So really speaking to how age and physical fitness are really tied together in the treatment of myeloma. So I hope that so far with this first part of my talk, I've convinced you that the biology of normal physical aging, of immune function and of myeloma biology are all linked, and they contribute to our clinical risk. And by that, I mean our outcomes when we treat myeloma. And we term this often as host-response biology. But what we need is a way to identify the different groups of patients so that we can predict their risk and perhaps also adjust their treatment so that we can improve overall outcomes. And to do this, we need a good way of assessing physical fitness. Now, the traditional way to do that was to use the WHO performance status, which is a very well-established and very quick technique that we can use easily in the clinic, but it's a bit crude and it's a bit subjective according to the person that's making this assessment. It doesn't really take into account factors like whether somebody's current physical fitness has been temporarily affected by their current illness, for example, a fracture from myeloma, or whether it's part of a long-standing deterioration in somebody's health. So although this is a very widely used method of assessing somebody's physical fitness, we can do better than this. And so in myeloma, the score that we often use, particularly in clinical trials, is the IMWG frailty score. And we know that this score, which categorises people into fit, intermediate fit or frail, can also be used to predict outcomes, both in terms of progression-free survival and also overall survival. The problem with this score is that it's quite complicated to do. There's lots of different components. It looks at age, but it also includes some quite long questionnaires about other health conditions and about the different activities that somebody's able to do for themselves in their normal day-to-day life. And so it's quite difficult to implement this in a routine clinical setting, although we do this score a lot in the setting of clinical trials. The other really big limitation with this score is that if you look at age at the top there, if you were aged 80 or over, you automatically score a 2, and that automatically puts you into the category of frail. Now, that might be reasonable for the majority of patients, but I think it does a disservice to some of our patients. To give you an example, I saw a patient, a new referral in clinic this week, who is in his 80s and has been referred to us with suspected myeloma. And the main symptom from his point of view that's bothering him is that 2 weeks ago, he had to stop doing his hill running. So up until 2 weeks ago, this man in his 80s was regularly doing a local circuit near his house, running up and down hills. And he described this to me in a large amount of detail. He is doing far more physical activity in a day than I am capable of doing. And he's 40 years older than me. It's really doing him a disservice to classify him automatically as being frail. A simpler model that we can use is the MRP score. So this was developed by the UK Myeloma Research Alliance, and it's been validated on a couple of different clinical trial data sets. Now, the really nice thing about this score is that it begins to incorporate some of these different clinical risk aspects that we've been talking about. So it looks at aspects of physical fitness in terms of the WHO performance status and of age, with all of the caveats I've just described in relation to that. It also incorporates aspects relating to the myeloma biology in terms of the ISS score. And then it includes CRP, which is a blood test marker that's giving us a little bit of an indication of the function of the immune system, and particularly in relation to chronic inflammation. And when these are all incorporated together, once again, they can be used to predict overall survival and also progression-free survival, but in a way which would be much simpler for us to implement in a real-world clinic setting. So the next important question becomes, can we use these risk scores to guide our treatment choices and also to improve treatment outcomes for our patients? And this is one of the things that makes the fitness trial such an exciting trial for us, because it really is a groundbreaking study in the way that it's using a frailty assessment score to look at stratifying treatment doses, really with the aim that if we can appropriately modify treatment doses before the toxicity develops, then maybe we can give patients a longer duration of treatment with fewer side effects and therefore improve their outcomes. So for me, this is a really exciting clinical trial, which is asking a really important question. And we're all desperately waiting for the results to come through over the next year or so. So we've talked about host response biology, but then we've also talked about defining subgroups of patients, which will let us hopefully identify people that can tolerate different levels of treatment with the goal of, we think, improving outcomes. And this is really moving into an era of stratified medicine. But these clinical scores that we've talked about have limitations. And so the next thing that we need to think about are there any better tools that we can use to better guide our treatment decision-making? And there are lots of different aspects that we can consider here. So can we take, for example, some of the work that we're doing into the lab at the moment and translate that into the real-world clinical practice setting? Or can we start to use medical technology to give us a more accurate assessment of somebody's physical fitness in their day-to-day lives, rather than just a snapshot when we see them in clinic? Is there a way that we can take advantage of all of the routinely collected clinical data that exists on our medical records? And for most of us, our GP record holds a whole wealth of clinical data about us. Can we in some way incorporate that into our assessments that we make of somebody's ability to tolerate treatment? We routinely do a whole set of different radiology tests with our patients. So that might be a whole body CT scan or a whole body MRI scan. But we only really use this to look at whether the myeloma has caused any bone damage, when in fact there's a whole range of additional information that we could glean from these scans if we could find the right way to do it. So these scans could give us information about muscle mass, which probably correlates to muscle strength. Or it could tell us about the distribution and the amount of fat within our bodies, which might give us some important information about not just obesity, but about the balance between muscle and fat. The problem is that this is going to be really complex to pull out all the relevant bits of these data. And so we're going to be very dependent on using computer-based algorithms and computer strategies to allow us to extract this information. And finally, we should think about aspects of cognitive function. And this is something that Chris and I are particularly interested in looking at the moment, and really trying to understand the impact that a diagnosis of myeloma has on our cognitive function and our ability to process information and make decisions, but also the impact that our treatment has on our cognitive function. And if our cognitive function is very impacted by myeloma, then that could have a really significant knock-on impact on our ability to live independently. So in the ideal world, we'd be able to take aspects of all of these different elements, incorporate them together with clinical risk scores in order to be able to deliver much more personalised treatment for our patients. Now, this is the future, but what can we be looking at now? Well, most of you probably know about Chris's Transform sub-study within the fitness trial, which is a really interesting sub-study looking at whether by fitness tracking a patient, so by asking them to wear a device about the size of a normal wristwatch, but to wear it continuously over a period of time, whether that's going to give us a better insight into a patient's overall fitness, and whether the information that we can get from this fitness tracker is then correlated with what happens as they start treatment and the side effects they get from that treatment and their overall level of physical fitness. So Transform is still recruiting at the moment, and it'll be really interesting to see what data that gives us and where it takes the field of medical technology in myeloma next. Going back to this slide that I've already shown you about the work that we're doing in immune profiling in myeloma, we're hoping that with this work, we'll be able to identify some potentially quite simple markers that could be translated into clinical practice. Now, that's probably not going to be delving down into a particular immune cell subset, but it might be looking at the cytokine or immune chemical profile of an individual, and that might give us some really useful information. And next, we need to look at how we can integrate all of this information together. And as I said before, there's potentially a vast wealth of information that we're going to get here. It's going to be massive, massive data sets for each individual. And so we need to look really carefully at ways that we can integrate this information, process this information, and use it to give us some useful clinical outcome models. And this is going to require a vast amount of computer expertise and processing power. And we're moving towards using artificial intelligence to help us integrate all of this information and turn it into something that's a useful model that we can then look at in the clinical setting. So now we have the importance of host response biology, which we hope is going to allow us to better define different groups of patients and offer stratified medicine, and then utilise more detailed information into clinical scores so that we can develop better and more dynamic scores and strategies for managing patients. But why is it that we want to do this? Well, ultimately, what we want to do is to be able to deliver much more personalised treatments for our patients, which meets their needs and expectations in terms of what they want out of their treatment, that gives them the best possible control of their myeloma with the minimal possible toxicity from their myeloma. So what do we think the next chapter is going to bring, or what do I think the next chapter is going to bring? I think there's several important questions that we need to be asking. One of these is, can we improve both physical and immune fitness alongside treating somebody's myeloma? And there are a range of different ways that we could think about doing this. And some of those might be very, very simple interventions. It might be relating to exercise programs or nutritional programs that we can run alongside our treatment delivery in order to improve somebody's physical fitness. Or we could be looking at augmenting somebody's immune function, or even trying to reverse some of those biological processes of aging. Now, people often look at me as if I'm a bit mad when I talk about trying to reverse some of these physical aspects of aging. I'm not talking about turning off the aging process altogether or reversing normal aging as such. But what I'm talking about is using drugs and medications that may be able to slow down or stop some of this immune senescence, so these poorly replicating cells that we see. And this isn't such a crazy idea. There's already a whole host of data out there that tells us that many of the drugs that we use in routine clinical practice in various different aspects of medicine are also having important impacts on how cells behave, how cells divide, and this includes cells of the immune system. And some of these drugs really are very routinely used drugs, things like the statins that we use to manage cholesterol or metformin that's used to treat type 2 diabetes. And there's some emerging data now that suggests that even some very simple vitamin supplementation could make quite a big difference to the way that our mitochondria function within our cells. In the case on the right here, it was looking in particular at muscle mitochondria. And that by modifying our mitochondria through vitamin supplementation, we can reduce the amount of circulating inflammatory cytokines, so reducing that chronic inflammation, and in turn, improving our physical fitness. So while this is a really emerging technology at the moment, it's very early days with this technology, I think it's important to think about the things that we could be doing that aren't just directly treating the myeloma, but are working alongside our treatments of myeloma to help us give better myeloma treatment overall. The next question becomes, how can we move clinical risk assessment from clinical trials into clinical practice? And I think at the moment, this is a really big challenge, because the reality is that for most of us in our routine clinical practice, we have waiting rooms full of patients, we are run off our feet, and we don't really have the time that we need to sit down and go through a long list of health questionnaires and activities of daily living questionnaires to help us actually do this clinical risk assessment. And this, once again, is where the outcomes of fitness, I think, are really important. Because if fitness proves to the myeloma community that taking the time to do these clinical risk assessments is going to enable us to better treat our patients, then we're going to have to look more closely at our routine clinical practice and how we can begin to incorporate these scores into it. And thirdly, and perhaps a little bit controversially, but I do think this is really important, I think we need to think again and think carefully about our clinical trial endpoints. And I had a really interesting meeting last week with a professor of elderly medicine who's got a real interest in frailty and how we assess frailty and how we should be running clinical trials that properly address the needs of patients with frailty. And he questioned whether the goal of our treatment for myeloma should really always be focused on duration of response and survival, which are those, classic clinical trial endpoints. And his suggestion was that we need to better align our trial endpoints with the priorities of the patients that we treat. And so in myeloma, that is going to be predominantly an older patient population. Well, and what might this look like? Well, this is probably going to be focused more on quality of life and avoiding toxicities of treatments and living independently and leading a good quality life in older age, rather than necessarily the duration of response that somebody has to a particular treatment. Now, that is a really big departure from how we normally run and think about clinical trials, but it would be a much more patient-focused way of running our clinical trials. I think we're already moving in this direction. It's really nice to see nowadays how much quality of life and patient-reported outcome measures are included in clinical trials. And I think that the work that David's presenting at ASH this year, looking at quality of life from our myeloma clinical trial patients, is really important. But I do wonder if there's more that we can do in our clinical trials to be a bit more focused on the needs and priorities of our patients, rather than what we think that those trial outpoints should be. And I think that brings me on to my conclusion. So I've really raced through that quite fast. So to conclude, the biology of normal physical aging, of immune function and myeloma biology are linked, and they contribute to the clinical risk when we treat myeloma, and we term this host-response biology. Defining different subgroups of patients will enable us to offer more sustainable and better tolerated therapy, and that we believe in time can improve outcomes. And we think of this as stratified medicine. But we do recognise that our existing clinical scores have limitations, and we now need to focus on developing better and more dynamic strategies, and we term this profilomics. And incorporating host response biology into our clinical risk scores will ultimately enable us to redesign our treatment strategies so that we can deliver truly personalised medicine in the field of myeloma. And so with that, I want to just conclude by saying thank you to all the many different people that I work with in the Leeds Myeloma Research Group. And I'm sure some of these individuals will be familiar to many of you on the call. And also a big thank you to all of you that are enabling these trials to run and to be designed, and for the data to come out of these trials. And obviously a massive thank you to all the patients and volunteers that we look after as well. And that, I think, is everything that I had to say. Let me just stop sharing my slides so I can see all of you.
Thanks, Frances. That was a really fantastic overview of what is a really complicated topic with lots of different aspects to it, but obviously of real importance to us in treating myeloma. If people have got questions, by all means, I'll open up the chat, so you can pop questions in the chat, or it's quite a small group, so just pop your hand up and we'll come to you. Can I perhaps start? So I was interested in this this thing that we always talk about age, and you were it's an interesting sort of anecdote about this chap that you saw in clinic this week, and we do see people like that, don't we, that are really very elderly but actually very fit. But I'm also struck that we sometimes see people who are quite, on the face of, well, they're young, and on the face of things are good candidates for kind of aggressive treatments, and we tend to, if somebody's in their 40s or 50s and they have myeloma, it's almost kind of unspoken truth that you go in with intensive therapies. I'm just wondering, are people, is there do you think we should be looking at those, younger groups of patients to try to pick out frail people? And similarly, actually, should we be escalating treatment more in those elderly people? Because I think you'd be quite brave to think about doing intensive therapy and transplants and so on in somebody in their 80s. But actually, if he's running up hills more than I am, maybe I kind of feel that should we be broadening this a bit? Because we tend to think about it as an issue in elderly people, don't we?
So, yeah, I think that's really important. And I think there's probably several different elements to that, isn't there? So I think one of the big questions is actually, with our more intensive strategies that include a transplant at the moment, are we actually beginning to move away from that as a strategy in general? Because we have more and more newer treatments coming through, and thinking particularly about DRD that's just been approved in the first line setting for the non-transplant eligible, where actually the outcomes from DRD might not be that different from going through our most intensive strategy and then having a transplant. And so I think these newer treatments coming through does slightly shift that question a little bit. And I think it shifts it more away from using a transplant strategy in the younger but people who are of less fitness, rather than, I don't think I'd wish a transplant on anybody in their 80s, no matter how fit they are, because I would still worry that sort of the biological reserve isn't there, and transplants are horrible. We've seen that time and time again, haven't we? But I do think it becomes much more important to think about global physical fitness in all of our patients. And I feel like I've seen quite a number of patients recently who have gone down a transplant pathway and perhaps would have been better served by going down an alternative pathway that wouldn't have given them such a setback in their physical fitness, and might have allowed them to get a better quality of life back more quickly if we'd actually had a better way of assessing their fitness at the outset. So I do think it's really important. I think that the more our treatments change and evolve, the more important this is going to become. And we're going to be very soon, we hope, faced with the question of who do we treat with bispecific antibodies? Who do we offer CAR T treatments to? Although these treatments are always just a few months away, and they're forever a few months away, I do think that eventually these are going to end up in our clinical practice. And so we're going to have to think really carefully about these issues of properly assessing physical fitness and how that's going to be playing into somebody's response to treatment.
I sometimes think it's quite odd now, given everything you've discussed and what you were just saying about and all of these new therapies. I sometimes think it's a bit odd that the first thing we do when someone comes into the myeloma clinic on their first visit is decide if they're a transplant candidate or not. And then everything after that is kind of determined by, we saw that in myeloma 11, but the trial's still running like that. You're transplant eligible or you're transplant ineligible. And that's the kind of first treatment decision. And we do that without having any of the, more refined data that you've been talking about today. So perhaps that's something that needs to change.
Well, I think another part of that question as well, and you sort of mentioned this at the beginning, is actually maybe our fitness changes as we go through treatment. And we don't know this yet, but are these fitness assessment scores dynamic? And the fitness study is going to give us some of that information, but we may well be doing people a disservice by starting them on one line of treatment and committing them to a particular path, where actually their fitness might improve considerably once we've dealt with the myeloma, once the myeloma is under much better control. So yeah, I think this is going to have to change, isn't it, with time?
Lisa, I'll come to you in just a moment. Someone's put a comment in the chat, and I'm sorry, it's a short form login, so I don't know who this is, but thank you for the talk. One simple approach is joint working with the care of the elderly physician. Fitness and meds can be reviewed and adjusted, patient desires reconsidered without specific scoring systems. Any comment on that?
So in principle, I think that's a wonderful idea. And actually, we would love to have a really multidisciplinary clinic, wouldn't we? Where we had somebody from care of the elderly, somebody who's an expert in symptom control, somebody that can focus on palliative care and end-of-life scenarios that we face quite frequently in clinic. We'd love to have a dietitian and a physio and all sorts of different people working with us in our clinic. And I think that would be the best way to deliver care. That would give us the most holistic approach to the care that we give. The trouble is, at the moment, we're constrained with what we're able to do within the NHS. And much as we would love to have a care of the elderly physician working with us, right now, that's not something that we can do. And so we need a way in the short term, until we can, change our models of care, we need a way where we can be a bit more uniform in the way that we think about physical fitness, and that you can have the same quality and the same level of care, whether you're being treated in the tiniest little cottage hospital or the biggest teaching hospital, that you have the confidence of knowing that your holistic needs are being considered in the same way, and that all of these different aspects are being taken into account. So I think there is still a role for a specific scoring system for now, but I agree we absolutely should be working towards a much more holistic delivery system than we've got at the moment.
Maybe part of what those scoring systems can help us with is identifying who we need specifically to ask for help from a care of the elderly physician and get their expertise on board. Lisa, did you have a question?
It wasn't a question, actually. It was just an observation that you might like to consider. You could talk about people running up hills, and I mean, I used to be a very big sports person myself, but at the moment, as long as I've had myeloma, I've been a full-time carer for my husband who has advanced Parkinson's. And to be quite honest, I know I'd be rather running up a hill than the day-to-day things involved with that, lugging wheelchairs and mobility scooters about. So maybe you perhaps need to put in somewhere, and if you do a questionnaire or anything like that on fitness, you include that. Because I would imagine that most elderly people, they've still got a husband or wife or partner, but maybe actually in that same position as myself as a carer. And I don't get a great deal of help either. So that was just an observation, not.
No, thank you. That's a really important observation, actually, and it feeds into some conversations that Chris and I have been having recently about how we shouldn't just be thinking about the patient as an individual, but at the whole support network around them, about their carer, or if they have caring responsibilities. I think it's something that we're not very good at talking about, and we probably do neglect more than we should. And perhaps it is, again, and maybe this comes into some of the endpoints that we should be thinking about in clinical trials as well, that we're not treating a patient in isolation, are we? It's part of a much bigger community of people, and maybe we need to be thinking about ways that we can incorporate that into some of our trials as well as our routine clinical work. So I think you make a really important point.
Any other questions for Francis? Okay, well, we've yeah. Sorry, I wasn't sure if someone was speaking then, or if that's feedback on me. I think it was feedback. Okay, so just remains for me to thank you, Francis. That was a really interesting talk, and I think it's a really interesting topic, and it's one that we're going to be hearing, I'm sure, a lot more about over the coming years, because it's really, I think, at the heart now of how we kind of improve care for people with myeloma, and actually lots of other other diseases which become more and more prevalent as people get older and frailer. So this isn't even just about myeloma, it has much wider implications. So many thanks for the talk, and thank you everyone for joining us.